All right, guys. So the rule for tonight is stay on time. So we're going to do that. The conversation here is about mechanical support in structural heart disease. We know it's an incredible time in our field. We got a bunch of tools that we didn't have before, and that allows us to take care of patients that we never really could take care of before, including critically ill patients. One of the things I think it's really, really important for us to maintain is this collaboration. This field came out of a collaboration between interventional cardiology and cardiac surgery. That's what this meeting's about. It came out of subspecialization, and I think the really important thing for us to maintain is shared outcomes. These are the tools that allow us to do more, including in structural heart disease. What does it allow us to do? What does it really do? What do these mechanical support items do? They buy us time. They buy us time to think during a procedure in complex patients, and they also stabilize patients that are critically ill. So I'm going to go through a couple of cases and talk about how mechanical support made a difference, I think, for these patients, and go through that. So this is a vignette here, 54-year-old history, a gentleman that has all the typical risk factors, and he presented with respiratory failure, hypoxic respiratory failure. This was his initial EKG. I think if you look closely, there's some abnormalities. It doesn't meet, I don't think, STEMI criteria, but something ain't right, and especially in the inferior leads. And he showed up. He's clearly in heart failure, and he's got a troponin elevation as well. And this is his initial echo. And again, you see something's just not quite right. So I'm going to play it one more time. But you see something here that's flapping around, the inferior wall maybe not moving as well as it could, and something here. He gets taken for cardiac cath. This is at an institution that we work really closely with. That's not exciting. And this is what his coronaries look like. So this was implanted, and it bought the patient time. And he entered the transfer portal. Once he arrived, a TE was performed, and he actually was taken pretty quickly for an upgrade for an axillary 5.5 because he was still decompensated, and you saw his legs; they weren't ideal. And that really facilitated, I think, a lot of his workup and a lot of his evaluation. So what became apparent is that he had a papillary muscle rupture, and then with these images, there was a heart team discussion. And again, that's a big part of this, is having shared outcomes, shared decision making. He really stabilized with an Impella 5.5, and so I think that really allowed an opportunity to discuss a lot of these things. But ultimately, he was deemed to be most appropriate for percutaneous therapies, and his anatomy was pretty amenable for that. So we went for MitraClip and started off on the medial aspect. And this is with one clip, a substantial reduction. And then placing a second clip, got a really nice result. He actually trapped his PAP there, which I thought, Dr. Macris is here. I don't know if you remember, but we actually showed this to you, and he was like, "Why are you worried about that PAP?" We stared at this PAP muscle for some time. Right here, but obviously the patient stabilized with that. So then a couple of days later, he returned to the cath lab, ended up getting PCI to this circumlesion, and then soon after that was extubated and ultimately discharged home, and then returned several months later for full bypass. and did really well. So clearly an example where a patient really did tremendously well, and I think what stabilized the patient was mechanical support, allowed an opportunity to treat a patient in a complex way, and ultimately he got a definitive and a really nice result. So here's another case. Again, really, I think a more tricky case and frankly a more frustrating case. And I think it just will highlight some of the challenges that we face as we have more of these tools. So this gentleman's a lot older. He's in his 80s, already on dialysis, but peritoneal dialysis, has a left AKA, has history of HIT, and already known to have aortic stenosis. And now he's sick. He showed up and he was in distress, but he's got a huge family, and they're all caring, and they're very much advocating for this gentleman. Here we are, we look at his echo, he's got LV dysfunction, he's got aortic stenosis, and he's got significant MR, and of course he's got significant coronary disease as well. So this is a real challenge to try to figure out how to manage this patient most appropriately. His right coronary was okay, but he has LAD, circ disease. He was initially, a balloon pump was placed. Again, the same idea, heart team discussion. And ultimately, a decision was made on this patient with a lot of complexities to take him back to the cath lab. He was taken, he had a balloon aortic valvuloplasty, ended up getting an Impella placement, and then, and I think a fairly good, quite good PCI result to his circ left main LAD. Impella got removed, he had marked ST depression, but he really never recovered. And he did okay for several days, but it just slowly continued to progress. And this just was very frustrating. His EF improved a little bit, but clearly he still got bad aortic stenosis despite a BAV. So how do we manage these patients? Now we've got more tools. We're taking care of patients that are more complex. We have the opportunity to do it, but we're held responsible for these patients and their outcomes, and that's a lot of money and a lot of resources to be utilized on a critical patient. So we got all these tools. They buy us time, but I think trying to figure out what's the most appropriate way to manage these people. How do we identify these patients earlier, and what kind of decision-making tools do we have that are going to help us more accurately identify patients that are really going to benefit? And with that, I'll wrap it up with a minute left.
Thank you.